good evening everyone. Today we'll discuss about the bladder related how to approach different kinds of bladder and how do you what is the history that will help you in guiding what kind of bladder that is. So before that we'll understand what are the various nerve supply of bladder. So generally we have both sympathetic nerve system and parasympathetic and also somatic nerve system to the bladder. So the parasympathetic is the one which helps in micturition. It is from S2 to S4 like in the somatic so parasympathetic also is from S2 to S4. It is supplied by pelvic nerve, so it will supply to the M3 receptor and cause detrusor contraction, whereas sympathetic is the one which helps in the relaxation of the bladder and so that it will prevent the micturition. It is supplied by hypogastric nerve. It is supplied between T10 to L2, so it causes beta 3 stimulation and causes relaxation of the bladder. So these also sympathetic fibers also causes internal sphincters contraction by alpha 1 receptors. That's how it will relax the bladder and prevents the micturition. It stimulates both beta 3 relaxation detrusor muscle and cause alpha 1 agonist in the internal sphincter that causes internal sphincter contraction. Whereas one of nucleus is a pudendal nerve. It supplies the external sphincter, so it causes external sphincter contraction so that it prevents the micturition. This is the pudendal nerve, that is somatic supply. So what happens actually in this is when there is a bladder fullness. Let's say the bladder is filling up with urine. So let's say it reaches particular level. It sends the afferents go to the bladder. From the bladder it goes to the spinal pathway. It leads to the pontine nucleus. The pontine, there are centers for micturition, that is Barrington center, and there is also storage center. So Barrington nucleus is which helps in micturition. So it will assess how much amount of urine is there. So it will send a center to the, it will again send the to the cortex. It will ask the permission of cortex. What, like let's say I'm in class, so it cortex will, you're in a class, you can't go for urination now, so wait for some time. You're around some people where you can't, it's a social environment, doesn't allow you to micturate or something, so it will prevent it. So it will wait for certain stimulus, so it will send again. So it will ask the relaxation nucleus. There is a storage nucleus in the pontine, so it will stimulate the storage nucleus, which in turn stimulate the sympathetic supply. So it will relax the bladder and also contracts the internal sphincter. Let's say the bladder quality again filled up. It reached about 450 ml or something. So it is almost the time for bladder to empty. It will again send the stimulate to the spinal pathways. It goes to the pontine center. Now this pontine center will again ask for the permission of the cortex whether I can go for urine right now. So it will assess the social condition around it. So it will tell, okay, you can ask for, like if you're in a class, you'll ask for permission and go, or else if you're in a possibility, you'll go to washroom and use. So that's why it will, like, okay, you can go for urine now. It will stimulate the Barrington nucleus. Barrington nucleus is the micturiation center in the pontine. So it will in turn stimulate the parasympathetic supply. Parasympathetic will call contraction of the bladder. It also inhibit the sympathetic supply. That's how it will empty the bladder. The synergistic activity will be that. That's how the pathway will all occur. So these are the various pathways. The parasympathetic, through the, it will cause the contraction of the detrusor muscles, whereas sympathetic will cause relaxation along with the contraction of internal sphincter. Whereas pudendal nerve will mainly supply the sympathetic supply from the one-off nucleus, which will contract the external sphincter and inhibit the micturition. So that's how the stimulus will be sent to the pontine. Pons will tell the whether storage nucleus or the micturition nucleus, which is active based on the amount of urine is there. So it will stimulate as per that, so that it can empty the bladder. So based on this understanding, we will go and discuss about the various pathways and various case-based scenarios. So a 50-year-old female presented to emergency with complaints of unable to pass urine and was able to feel the sensation of bladder fullness, but she has to catheterize to empty the bladder. So here what is happening is patient was able to feel the bladder sensation. So her sensory component is normal, but she was unable to pursue, she was unable to empty the bladder. So this might be due to the condition like any motor supply of the bladder is abnormal, like any motor nerve supply to the bladder is normal. This is called as a motor atonic bladder. Maybe the sensory part of the nerves is normal, but motor part is affected. So that's why she was able to perceive the sensation of bladder, but was not able to empty the bladder. This is called as a motor atonic bladder. In that cases, you mostly advise for go for catheterization, so empty the bladder on emergency basis. A 62-year-old male known case of diabetes was brought to emergency with complaint of having not passed urine, unable to pursue the bladder fullness, but was able to initiate voiding voluntarily. So here the 62-year-old male is a known case of diabetes. So he was brought to the emergency that he has not passed urine for a while. So he was not able to pursue the bladder fullness also, but they can find, might be able to feel some abdominal distension or something. But he was unable to initiate the bladder voiding. Like when he asked him to micturate normally, he was like, when he asked to voluntarily micturate, like when you try to voluntarily micturate, he was able to voluntarily micturate normally. So here the problem is he was unable to perceive the bladder unless the sensory input goes from the bladder fullness. The spinal cord or the pons center will never know that bladder is full or not. So here the problem is in the sensory pathway where he was not able to perceive the bladder sensation fullness or something. So the bladder was not so the spinal cord or pons center doesn't know that bladder is full or not. So he was not able to perceive the bladder fullness, or the bladder is distending. He was not having any sensory input that goes to the spinal cord or pons center to stimulate the micturition. So when he was able to voluntarily start micturating, he was able to micturate normally. So this might be a case of sensory bladder, sensory atonic. The problem is in the sensory pathway. Sensory atonic bladder is a sensory atonic where the sensory supply is abnormal. So it was not able to stimulate the micturition center or motor pathway. So he was not able to involuntarily go. It's a reflex. The reflex pathway is not occurring. So when he was able to voluntarily start micturating, he was able to micture because motor part is normal. This might be a case of sensory atonic bladder, maybe related to diabetic neuropathy or something. So that might be a possibility. So sensory atonic bladder is this case. A 53-year-old male admitted with the complaints of lower limb weakness and with the involvement of right more than left leg. With absent reflexes of knee and ankle, she had low back pain radiating to leg since last 2 months. Now she was brought to emergency with complaint of not passing urine. So when you ask to dissect the history per se, she has weakness of lower limb weakness like asymmetric lower, like right more than left since long time. She has also absent reflexes. So now has also radiating sciatica kind of pain. So this might be a case of so the problem is by this time you might think generally we tell if there is a radiating kind of pain from the back, that might be a case of compressive myelopathy where something is compressing. That can be disc prolapse, something that can be vertebral compression or whatever it is. So when there is a sciatica, that radiating kind of pain is that nerve root is being compressed. So there is something, the radiating pain, that the spinal pathology you can tell there is lower limb weakness is there and also hyperreflexia. So this is element kind of weakness. So by this we can think that since the element vision, there is some nerve roots that are supplying the lower limb, that is something from the L1 or L1 from down the L1. Generally L1 L2 is where the lower limb start. From down the L1 the lower limb pathway is in lower motor neuron pathway is involved. That's why the reflexes are not there, and also patient is having weakness. So what is the cause? Is also stagnation. Maybe that nerve root compression around the spinal cord, compressing this nerve roots after coming out of spinal cord, this might be a reason. So this might be a case of cauda equina syndrome where you find asymmetrical weakness, which is element type, which has absent reflexes, and also you might find anesthesia along the perianal area and all. That is also asymmetric. But bladder involvement is highly unlikely in cauda equina syndrome. So generally because bladder fibers are more central. So but they might be involved very late. So like in this case, maybe late involvement, this might be a case of cauda equina syndrome. But similarly, if this patient has some like lower limb weakness, which is more of symmetrical and has a more reflexes are exaggerated below, and upper motor neuron pattern is there, and also symmetrical saddle anesthesia is there. So that might be a case of conus medullaris, where the problem is in the spinal cord. That is a spinal cord involvement where you classically find UMN kind of lesion. So that might be a case of conus medullaris. That is how you differentiate. Conus medullaris is more symmetrical, and also it will have a more not absent reflexes won't be there, and also weakness will be symmetrical, and also saddle anesthesia will be there, and also bladder involvement is little early in the case of conus medullaris. So that is how differentiating part one. You'll find back pain, but it's more of low back pain. There is a difference between the low back pain, which is dull aching, where you find we can't localize properly. So let's say if the posterior column or spinal thalamic tract is also, you'll find have low back pain, but if that is dull and very unlocalized, you can't localize it per se. When a spinal thalamic tract is involved at all, where you can't properly localize. When tracts are involved, the low back pain which is there, you can't localize. But unlike when there's a compressive neuropathy where it compressing the nerve root or something, you'll find classical back pain which is radiating to along the nerve root. That is whether along the leg or something, you'll find classically. So low back pain needs to be differentiated. Some low back pains are due to the nerve tract pain, some nerve tract pain, that is spinal thalamic or posterior column. Some low back pain which are on the paraspinal muscle due to the muscle spasm. Whenever there is some fracture or something, some paraspinal abscess is there, or some root compression, there is obviously some kind of paraspinal spasm will be there. That is the low back pain that is causing low back pain. Always this also needs to be in when. Sometimes the muscle spasms are the most common cause of low back pain. So that also needs to become. So always ask what kind of character it is. If it is radiating properly, it is proper root compression pain. If it is just low back pain which is dull, which you can't localize properly, it might be a tract pain, maybe spinal cord tract is something involved. When it is a paraspinal muscle is there, when it is increasing on some movement, when it is decreasing on some other movement, maybe that some paraspinal muscle involvement is there, maybe due to abscess, that may be due to vertebral fracture, that may be due to some mass there or something else, that may be. Always what kind of pain is there is also important. So in this case, this might be a case of cauda equina syndrome where you find classical radiating pain with element kind of weakness, also bladder involvement is there. Whereas in the opposite with conus medullaris, where you find symmetrical kind of weakness with early bladder involvement and reflex are more intact, and saddle anesthesia is classically seen. A 60-year-old male present with complaints of neck pain and has quadriparese, has hyperreflexia and spasticity of limbs. He is complaining of frequent micturition, emptying small amounts of urine and couldn't hold the urine. So this is one more thing. Let's say 60-year-old male is complaining of neck pain. There is neck pain. Definitely there is neck pain. So here also you need to ask what kind of neck pain it is, whether it's localized or whether it's radiating, whether the pain is radiating to somewhere. So here is kind of, there is no radiation per se. There is, let's say there is neck pain. So there is no, they didn't mention anything about radiation or something. So maybe that may be due to the paraspinal muscles or due to the pathology in the spinal cord. So since there is quadriparesis, you always suspect the spinal cord involvement per se. So that might be a tract pain or some local compression that is causing the pain. So that is a possibility, and spasticity of limbs is there. So definitely spasticity and quadriparesis less, that something cord compression is there. So definitely generally if there is only root compression or nerve root compression, generally unilateral, whichever limb is involved, that will cause the root pain is there, that will only have motor weakness. But here complete quadriparesis, that means the spinal cord is involved. So that kind of neck pain with quadriparesis where spinal cord is being controlled, that is the corticospinal tract is involved, that is causing hyperreflexia below. At the level there will always be element kind of thing. Below the level always hyperreflexia, because below the level upper motor neurons are still passing through. That's why those are being compressed. Always human kind of lesion will be below the level. At the level element neurons are coming out. That's why at that level you will have absent reflex. Let's say the lesion is at C5 C6, you will have absent biceps, but triceps, knee reflex, ankle reflex all will be exaggerated because C5 C6 nerve roots are already coming out. So that's why those will be absent. Below that always be hyperreflexia will be there. So also spasticity will be there. Human kind of lesions will be below the lesion, and is also complaining of frequent micturition. As I told you before, so what will happen in the bladder when the bladder is able to completely full, is able to fill something. Let's say 200 ml of bladder is full. It will send the sensory input to the spinal cord. From there it will go to the along the spinothalamic tract and also sensory tracts. It goes to the pontine center. So when the pontine center will tell you whether to hold the urine or pass the urine. Let's say 150 ml. You can actually storage of bladder is very high, so it can actually hold till 450 ml, 500 ml also. When you can initiate, actually voiding reflex is initiated. So what happens is when 150 ml is full here, let's say 150 ml is full, it is sending reflexes to the upper along the spinal column. But here the problem is there is compression of spinal cord at cervical cord. So this reflexes whatever the sensory input is not going to pontine center. So there is nothing. Pontine center can't inhibit this micturition. What will happen? It will become automatic bladder. So it doesn't take a pontine center. So 150 ml is also it starts emptying. So because pontine inhibition is not there. So generally pontine inhibition, it will hold the urine for some time. It will be able to store the urine for some time until it reaches certain level where it can stimulate the Barrington nucleus or micturition center where it can start micturating. But this control of ponds or something is there. This is called infrapontine bladder where the pontine control is there. So how much amount of urine is it will start emptying. So small amount it starts voiding. So frequent micturition he will go. There will be small amount of urine. He keeps on frequently voiding small amount of urine. Again he keeps on he can't hold urine. Before he goes to bathroom also he starts voiding. So this is a case of infrapontine bladder, which is also called as automatic bladder, where it becomes where there is no pontine control. It counts automatically because sensory relay is not there in the pontine. So for small amount of urine also there is no inhibition of pontine, it starts micturating. This is the cause of infrapontine bladder, where you can't hold urine frequently. Small amounts of urine is there. They keep on passing small amount of urine. They can't hold urine till they go bathroom also sometimes. A 48-year-old female has headache and is complaining of unable to hold urine in social situations. Otherwise, she has normal urine passage. So this is one more example. Let's say you are in a classroom. So she's in a meeting where she can't actually go for the washroom. She was presenting actually where she can't use the restroom. Generally what is there, social inhibition will be there, so that you'll actually when I told you that when the sensory input goes to pontine will send it to the cortex again to tell whether I can go in this situation or not. Generally cortex if it is there in the where the social conditions are not permissive, it will actually inhibit the pontine center to actually hold it for some more time. So if the problem is in the cortex, let's say some frontal tumor is there, like this headache is there, some frontal tumor is there, so this inhibition will be lost. So the social inhibition will be lost. So when the pons is there, pons will actually ask cortex. There is no social inhibition. So generally they pass urine generally in the social condition where you generally don't pass in some meetings or something. Those social inhibition will be lost. Other than that, the bladder function is absolutely normal. But this social inhibition where you generally we can't have to hold urine in certain social condition, that will be a problem in these conditions, in these cases. So this social inhibition problem is there. This is called where social inhibition is there, social bladder, where social inhibition is lost. So this might be due to the cortical condition, which is called suprapontine bladder. So these are the various kinds of bladder. And 40-year-old female, history of uterine prolapse and history of LSCS, now has no developed passage of urine on coughing or straining of stool. So this is one more condition where a 40-year-old female has uterine prolapse. So she has prolapse history. So pelvic muscles, more probably after LSCS or something, generally pelvic muscles become weak. So after that, she was unable to hold urine. So she was passing urine on increased straining or cough on, because of the increase in intra-abdominal muscle, rather than not. This is not due to the increased bladder contraction or something, because of the increase in intra-abdominal muscle pressure, intra-abdominal pressure, sorry. So while coughing or something, this is mostly stress incontinence. This is due to the decreased pelvic floor muscle strength. So you will advise Kegel's exercise for now. Then after generally you advise for Kegel exercise only. After that you can advise beta 3 agonists or something where to relax the bladder or something. But generally you advise Kegel's muscle exercise to strengthen the pelvic muscle floor. So this is the case of stress incontinence. So before one, where the infrapontin is mostly called urge incontinence, all element bladders are called as overflow incontinence. So these are the various kinds of bladder we generally discussed. So this is uninhibited bladder or detrus or hyperreflexia, where suprapontin is a cause, where frontal tumors or parasagittal meningiomas or any anterior communicatory aneurysms are more cause, or normal pressure hydrocephalus also can cause incontinence. These kind of incontinence will be there. NPH, frontal tumors and meningiomas, where bladder sensation is normal, size of bladder is normal, ability, everything is normal. Only social inhibition is lost. Only socially, when they're in social condition, they can't hold the urine, they have to pass urine. Other all on urine. Generally, when they are going there, they'll generally give anticholinergic medication to inhibit the detrusor contraction. M3 antagonist, like any M3 antagonists are generally they inhibit the contraction. Anticholinergic medications are given. What are the anticholinergic medication? You read about it and tell me. So human disorders of this is called automatic bladder, where is infrapontin bladder. So where the spinal cord trauma or compressive myelopathy, like we discussed in our case, or any transverse myelitis or something, where the bladder sensation is interpreted. It is not related to pontine center. Size of bladder is small. Very small amount of urine is also dispersed. Ability to initiate absent. They have urge incontinence. They can't hold urine. They have urge incontinence. Residual urine is very small. Sphincter tone, perianal sensation, they are all normal. Bulbocavernal reflex are all normal. Generally they don't have any superficial reflex are all normal in a human kind of lesion. So generally self-intermittent catheterization is required in these cases. Autonomous bladder or detrus or reflexia. Autonomous bladder is generally is a overflow incontinence which is in an element bladder. So this is in the case of cauda equina syndrome, like it is conus medullaris syndrome or spinal shock, where bladder sensation is absent. Generally bladder is large and they can't initiate urine. They have overflow incontinence. After passing urine at some time, they because of the overflow it passes urine. Residual urine is very large. And generally anal sphincter tone is lost, perianal sensation are lost, bulbocavernal reflexes all are lost. These are all lost in case of LMN bladder. So generally you have to continue catheterize. This is called sensory atonic bladder, where diabetes mellitus or amyloidosis, which predominantly involves is diabetes mellitus, amyloidosis, stapes dorsalis, which predominantly involves sensory fibers. This is also LMN bladder, but is more of sensory component. So diabetes mellitus, amyloidosis, stapes dorsalis are the more common cause, which predominantly is sensory fibers in this sensation bladder. They don't feel any bladder sensations. Unless you feel bladder sensation, you can't initiate a reflex pathway. So, but when they can voluntarily initiate the bladder, initiate the voiding. So they can initiate the voiding, but they won't have reflex pathway that can pass urine or something. Generally, in this case also size of bladder is large because they are not able to perceive the bladder sensation. So anal sphincter tone is normal, but perianal sensation is decreased because sensory involvement is perianal sensation is decreased, and bulbocavernous reflex is also absent because sensory component is abnormal. So then third is motor atonic bladder, where some lumbosacral involvement is now root compressed in the motor pathway or meningeomyelocele or lumbar canals, where the motor nerves are more commonly involved. In this, the problem is they are able to feel the bladder sensation, but they can't empty the bladder on their own. So in them, the bladder is large. They can't initiate voiding on their own. In the case of sensory atonic, they can initiate the voiding on because motor pathway is intact. But here motor pathway is not intact. They cannot initiate the voiding on their own. They also have overflow incontinence. Large fibers are involved. But here anal sphincter tone is lost because anal sphincter tone involves motor muscle fibers. Anal sphincter tone is lost in this case, whereas normal in the case of sensory atonic bladder. But perianal sensations and bulbocavernal reflexes are all normal in the case of motor atonic bladder because it's morely sensory dependent. In all of the case of LMN bladder, continuous catheterization is what we advise. Regarding the medical management, I'll again make a video what kind of medical management use for stress incontinence, urgent incontinence, overflow incontinence again in the different video. But read about it. I want you to read about it, but I'll also make a video on that. But these are the different kinds of bladder where you find automatic is more of infrapontin bladder, autonomous is LMN bladder. In that there is sensory atonic and motor atonic. You can tell it by differentiation by anal sphincter tone and perianal sensation, whereas perianal sensation is decreased in the case of sensory, whereas preserved in the case of motor. And you can tell it by uninhibited, where social incontinence is there.
Automatic is very small. They'll frequently pass urine, small amount of urine. They keep on passing. They can't hold urine. Whereas overflow, they can't. They won't pass urine until you catheterize. They generally won't pass urine. Otherwise, when the bladder is very full, they will pass urine. So these won't pass urine. These frequently pass urine. This automatic bladder. So that is it. Thank you.
So these are the various treatment options that are available for urgent incontinence. One is these are all anticholinergics, that is oxybutynin, tolterodone, transdermal patches also can be used, but better, which long-acting ones are better preferred when compared to the short-acting ones. So always these are the drugs that are available for urgent incontinence, whether oxybutynin or tolterodone or what normally we use in the case of urgent incontinence. So these are the various for stress incontinence. There are various different things we can. Once we can try behavioral therapy where you advise Kegels exercises and also you ask them to hold the urine for a long time in between the incontinence. So that is how generally pelvic floor orgasm and biofeedback therapy can be used. Alpha adrenergic stimulants are also can be used, but they are not FDA approved per se. Duloxetine is one drug which increases the sphincter contraction. That is one more thing that can be used in the case of stress incontinence, duloxetine. And other devices like extracorporeal magnetic innervation chair, there are many options that can be used. Intravaginal support devices can be used, pessaries can be used, urethral ablation insert can be used, invasive treatment, the colpo suspension procedure can be used, tension free vaginal free tape, injection of bulking. These are all various treatment options that can be used in the case of urgent. Most of them are surgical management. Medically, there are very few drugs that are available. Most of them Kegel is what we advise. But these are the drugs that can be used in the case of these are the various modalities that can be used in the case of urgent incontinence. Thank you.